So we're going to do postoperative musculoskeletal imaging, which on the surface is a seemingly very, very broad topic. And I remember back when I was a resident, whatever the body part was, no one wanted to read the post-op film, right? If I remember correctly, the post-op neck was the single least or most despised imaging study. Would always, in the days of films, it would go to the bottom of the films. But postoperative musculoskeletal imaging, I think, is among the easiest of the postoperative studies. And it really isn't that hard because the concepts are fairly global in that the same rules apply to almost every joint. And most of the joints behave as if they weren't operated on. So you can kind of use rules similar to that you would use in a non-operated joint. So what we're going to discuss is first off some specific pearls. I like to begin with pearls. Just everyone likes pearls because it piques your interest. Then image optimization. I've kind of gotten into physics in the last, probably decade. And I think in postoperative imaging, unfortunately, image optimization plays a huge role, and you really have to be careful how you do your images. Do a routine ankle, you can almost see anything, almost no matter what protocol you do. You may, once you get used to it, you can read almost through anything. Postoperative, that's not true at all. You really have to optimize your images. So we're going to do pearls, we're going to do image optimization. Then we're going to do global complications like seromas, hematomas, infection, RSD. And then we're going to talk about some specific procedures and how they behave. And this is similar to my marrow edema slide that I showed you before. This is a patient who had a knee surgery, was put in a long leg cast for the knee surgery, and again presents with this edema from altered mechanics. And I think that this is really scary, looking edema compared to the other cases I saw. But again, completely normal when you're in a cast. Okay, so let's do some pearls. It's a somewhat busy slide, but this is all on your CD. Every slide I'm showing you, and then some are on your CD. There are some complications that are common for all procedures, and I will emphasize them because it makes it easy. You learn 5 complications, it works for 10 joints, you got 50 complications covered. Post-op studies are less accurate than pre-op studies, surprise, 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 but they're not nearly as bad as you would guess. So you can be 90% accurate in real life in meniscal tears. Average radiologist who's got to master 10 different fields, I still think, and I give anyone who does that a tremendous amount of credit because your job is much, much, much harder than mine. Not that hard to be 90% accurate for menisci. Not that hard to be 80% accurate for postoperative menisci. So the delta is not nearly as great as you might think it would be. You just have to be logical and concentrate on morphology more than signal. We should use signal even less than we use it on virgin studies, but particularly on a postoperative study, signal, looking at signal abnormalities of soft tissue structures is where you get into problems. And this is specifically true for signal with inside tendons. And I'm going to show you a really scary example of it. How much marrow edema one has in response to surgery is based upon how much mucking around they did at surgery. So if someone did a clean amputation, just took a saw and cut off the toes, you will see very little marrow edema. If someone came in and scraped off to get very precisely all the infected bone off, you're going to see a lot more marrow edema. So how much marrow edema you see for how long is based upon how much aggressiveness, I'm not sure what the right word is, mucking around is the one that comes to mind, but again, my wife wouldn't like it. But that's basically how much marrow edema. So if someone's had an amputation, very little marrow edema. Someone's had a microdebridement, a lot of marrow edema. If you see debridement of soft tissues, whatever the soft tissue is, it's wider than it is deep. That's true for rotator cuffs, that's true for menisci, and that's true for the TFCC. We're going to spend a little bit of time talking about meniscal tears and the concept of signal conversion. And there's been a lot of this in the literature. But signal conversion is not a problem in looking at the postoperative menisci. If you use your signs as if it was a virgin meniscus, with one notable exception, that being if there's very little meniscus there, it's always retorn. Real simple rule. if they took out a lot of that meniscus and they come in with symptoms, it's always retorn, no matter what it looks like. So you use that rule. If that's not true, you look at the regular rest of the meniscus as if it wasn't operated on. You won't be wrong nearly as much as you think you will be wrong. When looking at tendon grafts or ligament grafts, pretend it was a normal ligament. If there's high signal in it, it's retorn. No trick. You won't be 90% accurate, but you're going to be 80% accurate. Okay, so this gets back to last thing. I'm sorry, skipped over it. So shoulder repairs may not be water or gadolinium tight. That being said, if I see gadolinium going to the subacromial subdeltoid bursa and they have not exercised, that's the key thing. That's abnormal. So the rules we used for arthrography are correct, but we did arthrography differently than we do MR arthrography. Who exercises their patients following MR arthrography? I would suggest not doing it. I think it creates more problems than it solves. And the major problem is you can't use this communication, which you could use if you didn't exercise them. So as long as you don't exercise them, you can look here, and you can see there's no fluid in the subacromial subdeltoid bursa, and therefore there's no rotated cuff tear. This wasn't a rotated cuff repair. Now, if I look at this patient here, this was a labral reattachment, right? And we've optimized these images, I think, so you can see this pretty good, right? Does this look like a normal labrum to you? No, it's a retorn labrum. That's all you need to do. You don't have to see it beautifully. If it doesn't look normal, it's a retorn labrum. Now, this was the scary one. A sagittal T1 weighted image, a sagittal inversion recovery image, open magnet, obviously trochlear chondromalacia. This was status post a quadriceps reattachment to the patella. Okay, how would you guys read this? I'm sorry? Torn, yeah, which is how I read it. And at surgery, this was absolutely normal. Absolutely normal, right? I think I wrote it up here. And the tip-off is, well, there's a lot of marrow edema here in the patella, right? What is the determinant of the marrow edema? How much mucking around they do, right? How do you reattach the quadriceps? You suture it in, you suture it in, you suture it in, you suture it in, you suture it in. So all this edema is because they reattached this to the patella, causing a lot of microtrauma to that patella. Marrow edema oozes out, right? So this edema in the quadriceps tendon is not because the quadriceps tendon is torn. It's because the marrow edema is here, is oozing out. And I should have known this because if this wasn't a quadriceps tear, these tendons would not be taut like this. They would be pulled back and buckled. So this is an example of two things. Don't look at signal when you're looking at postoperative tendons. And marrow edema is based upon how much mucking around, and if you guys can think of a better word, please tell me, I don't like it, they do. Okay, so this was not torn in surgery, and it was a personal embarrassment to me.
How many days post-op was that?
That was actually 2 months post-op. That wasn't even days. Okay. Well, thank you for allowing me to make a mistake that you agree is an honest mistake. But it kind of brings up the concept that be very careful except to looking at morphology. And if you look at this morphology, these tendons here are completely normal. I like the case because I think it's very demonstrative.
He was symptomatic, that's why they re-imaged him?
He had inability to fully extend his knee, which is why they re-imaged him. And he had inability to fully extend his knee because they thought he had arthrofibrosis in the end. That's why he was 2 months after surgery and had adhesive capsulitis. That's an interesting question. Clinically, if this was infected, it's pretty close to his skin. His skin would be red, it would be edematous, it would be pretty obvious clinically. If that was the case, could I exclude infection? No. And I don't think gadolinium would help. I would do a nutrispect nuclear medicine study, probably. Okay, so we talked about some pearls. And now we're going to talk about how to interpret them and a little bit about how to optimize images. So 4 principles of postoperative musculoskeletal imaging. Understand the original surgery. And again, you guys, or many of you, are general radiologists, and no one expects you to understand 50 different orthopedic procedures. Just know 4 or 5 orthopedic procedures, and that'll cover you for 90% of the things that you'll see. And we're going to cover those 4 or 5 orthopedic procedures. Number 2 is optimize images. And as I said before, this is something where you can't get away with suboptimal imaging because you just won't see what you need to see. Know the common complications. Again, there's 5 of them. I'll go through them. None of them are hard. And if you take home 1 point from this talk, if someone comes in 6 to 12 months after surgery with symptoms, consider that they had 2 concomitant conditions, only one of which was the symptom generator, and they operated on one that wasn't the symptom generator. Like shoulder and neck problems, commonly concomitant. They do have a rotator cuff there. They fix the rotator cuff there. The symptoms don't go away because they have a C5-6 disc that is causing their shoulder pain. They really had a rotator cuff there, but that wasn't a symptom generator. Someone comes in with knee pain. They have a 4-5 disc or a 3-4 disc. That's their symptom generator. They have a shoulder, again, a rotator cuff repair. They had a cartilage defect, and that's their symptom generator. So always consider, particularly in the hyperacute stage, that not that they were wrong or you were wrong or your partner was wrong in the original diagnosis. I don't mean that by any means. I mean that there's more than one thing going on, and there's a lot of patients where there's more than one thing going on. And the other thing was the symptom generator. You guys all get that concept? That is the single most important concept of this lecture because it comes up again and again and again. Okay, so here's a patient with a Dwyer osteotomy of the calcaneus, and you have to know that there was an osteotomy. That's all you have to know. And if there's an osteotomy, they did a clean cut, like an amputation, and there's little marrow edema. Doesn't matter if it was an osteotomy of the calcaneus, if it was a hallux valgus repair, if it was a tibial osteotomy for osteoarthritis, if it was a lengthening procedure, all osteotomies are the same. So one procedure you should know, not hard, and you probably all know it, is an osteotomy. Second procedure, tendon to tendon anastomosis. Patient who had an Achilles tear. Big, thick Achilles, little enhancement within the Achilles. So this is a tendon to tendon anastomosis. Can happen in the Achilles, can happen in the quadriceps, less common in the rotator cuff, but can happen almost anywhere. They all look the same. They can be big, they can have internal signal, but that signal should never look like fluid, and the fibers should be taut. Anyone know what this enhancing area is? Who's going to be a star? I didn't write it on the slide, so you can't cheat. That's a suture granuloma. Okay, how do we optimize images? Well, here's something where low field is better than high field. Less susceptibility artifacts. So actually, if you have a low field scanner, your post-op patients will end up being better on it. If all your scanners are equivalent field strength, the highest gradients is the one you want to image it on. The order of sequences, big is good, lesser than is bad. So never do gradient echo images. Almost always do fast spin echo images. Rarely do fat set. Do inversion recovery. Turbo gradient echo images are not bad, especially if you have really good gradients and can drop the TE low. Again, this is all in your handout. You want to increase your bandwidth as much as possible. When I do my texts, I say increase the bandwidth. They go from 140 to 160. I mean, you go from 140 to 500. You ramp that bandwidth up as much as you possibly can. Once you've ramped up that bandwidth, then you choose the shortest TE that you can. If you choose the TE before you ramp the bandwidth, you won't be able to ramp the bandwidth. You understand me? And the bandwidth is much, much more important. I used to use GAD very liberally. I still use it pretty liberally. But an important concept of using GAD is it's not that something enhances. It's all about morphology, right? So we're giving gadolinium to see morphology. Again, if you want to remember a second thing, first thing is remember initial misdiagnosis. Second thing is ignore signal as much as you can and concentrate on morphology. So you use GAD to see morphology, not to see if something enhances. oxymoronically, it's kind of interesting. I'm going to be a visiting professor in Roosevelt Hospital in a few weeks. And one of my first visiting professors about, I won't say how many years ago, but at least a decade ago, was also at Roosevelt Hospital. And I talked about this, and I made a really stupid mistake. And I said that when you do postoperative imaging, you want to have big voxels, which is absolutely wrong. And the reason why I thought you want to have big voxels is you got like a hip arthroplasty there, right? You got no signal. So you should make the voxels bigger to get more signal, right? Logical, but everything that's logical isn't true. And fortunately, the guy caught me after the lecture. He didn't embarrass me during the lecture, and I thank him to this day for that. He said, you're wrong. You want to have small voxels. So even though you lose signal on small voxels, you lose artifact greater than you lose signal. So your images end up being more diagnostic. So the artifact is the rate limiting step, not the signal. And by having small voxels, you minimize the signal, the artifact to such a degree that you get more conspicuity of an abnormality. So you understand that? But the most important thing is to ramp the bandwidth. So if you can't get the slice voxel size that you can with that bandwidth, go for a bigger voxel slice. Don't decrease the bandwidth. Fat suppression should be used with care. It depends on a specific procedure. And in your handout, I'll have a list of the procedures you can do fat suppression with. But when in doubt, use stir. Stir is relatively insensitive to postoperative changes. And here is an example. This is one of the O&I magnets that they're showing outside. This is a patient who status post an epicondylar reconstruction with a screw here. And basically, there is no artifact where that screw is. And you can clearly see that this is a nice, good reconstruction. So stir imaging works very well. And this is an area where low field is better than high field. Another example, a T1 weighted image, a T1 with frequency selective fat suppression, and an inversion recovery. So door number 1, door number 2, door number 3. Rank the artifacts in severity. The worst is door number 2, the frequency selective fat suppression. The best is door number 3, the inversion recovery. And you can clearly see this is a nice normal tendon to bone anastomosis. So stir is almost always your fallback sequence. Okay, what was rule number 2? Rule number 1 is remember that it may be an initial misdiagnosis. Rule number 2 is ignore signal. Very good. Gets free tuition next year. Just kidding. Jen. Don't tell Janice. So this is a T1 weighted contrast enhanced image, and this is a T2 weighted image. And guess what I call this? A rotator cuff re-tear. And they went in surgery, and the tendon was normal. And there is no abnormality of morphology. The myotendinous junction is where it should be. And enhancement doesn't matter. And signal doesn't matter. It's all about morphology. And I like this case too because it shows you, again, I like to show my mistakes, that it's not signal. It's morphology. And if you forgot the signal in this, you would say it was a normal postoperative cuff. And it's really hard to forget the signal. But you got to remember that you're going to overcall things if you look at signal. Okay, so we did pearls, we did image optimization, and now we're going to do global complications, right? And I see some of my Brazilian research fellows here, and I first put global in here when I lectured overseas. I thought, if no one else thought it was funny, at least internally I thought it was funny. Okay, the global complications for postoperative. Seroma, hematoma, and granulation tissue. I put them together, not that because they look alike, but they look pretty similar, so I kind of put them on one synapse. Reflex sympathetic dystrophy, someone had a question about that in the other session, and we'll talk about that. Infection, adhesive capsulitis, and the first slide I showed you, this weight-bearing cast-related edema. And this is order of frequency. Okay, so patient had a perineal tendon sheath debridement, and I forget how they presented, but question recurrent perineal problems. And they have this fluid collection anterior to the perineal tendons, right? Simple fluid, postoperative seroma, right? You can aspirate it or you can just leave it alone, and presumably you leave it alone. Shoulder surgery, had a medical student leaning on a patient. I remember when I was a medical student, first I did an anesthesia elective, and the anesthesiologist was standing the whole time. I'm thinking, and the rule, I just finished my surgical sub-intern, and my senior resident had a rule. He goes, don't stand when you can sit, don't sit when you can lie down, and don't lie down that you can sleep. That was his motto for how to handle. So having just finished that, this anesthesiologist is standing during every case. And I go to him, why are you standing in every case? You could be sitting. He goes, I'm standing so I stay awake. I go, this is not the field for me, Mark. But during that case, I'm leaning on the patient. And the surgeon kept on telling to me, stop, stupid medical stuff, if you're going to lean on the patient, get out of here. And the reason why he didn't want me to lean on the patient is because of what this medical student did. So he leaned on his patient during a rotator cuff repair, and you see the hematoma that formed in the anterior aspect of the chest or the humerus here. So hematomas look like seromas. They can look almost identical, but they get this lowest signal area sometimes. But I think if you use your rules and it looks like a hematoma, it's a hematoma. If it looks like a seroma, it can still be a hematoma. Do you understand that? Sometimes hematomas look just like seromas. And this is another hematoma in the spine with rim enhancement around it on a sagittal. Granulation tissue. Again, I put this on the same synapse because to me they're benign complications that resolve on their own, and they're right at the operative bed. This was what kind of surgery? Tendon to tendon anastomosis, and we see a nice big tendon, which you should expect to see. And we see some internal signal within this that's not quite fluid-like. If it's not quite fluid-like, nothing to worry about, and this is granulation tissue. Next complication we're going to talk about is reflex sympathetic dystrophy. This came up in my marrow edema talk. Exceptionally rare marrow edema. This is in the radiology literature. It's in the orthopedic literature. It's hogwash, okay? It's in there for a legitimate reason, but all legitimate reasons are incorrect. RSD very, very, very rarely causes marrow edema. If we take this entire audience, you will see 1 to 2 cases in your cumulative careers that cause marrow edema. That's how rare it is, okay? RSD is a trophic disease. You see changes in the skin and the subcutaneous tissues, and you'll see a hyperemic response. So when I used to image a lot of RSDs, I would always image both feet for comparison. You want to do a gradient echo T1 weighted image because you want to be able to see the skin. You want to use the dorsum of the skin because you don't get skin calluses there, you don't get occupational or recreational effects. And you can see the normal skin on the right side, the abnormal thickened skin on the left side, the skin edema on the left side. RSD is a trophic disease. You see changes in the skin, very rarely in the marrow. If you give contrast, you'll see enhancement, either in the joint space or in the subcutaneous tissue. It's hyperemic. So first complication, seroma, hematoma, granulation tissue. Second complication, RSD, doesn't show marrow changes, shows you skin changes. Next complication, infection and synovitis. And I put them together because they look very much alike. So here's a patient who had shoulder arthroscopy, another low field image, an inversion recovery image, a T1 weighted image, post-contrast, right? It's hard to see that this is contrast because it's not fat suppressed. So we see a joint effusion. Shoulder effusions, even in the setting of labral tears and cuff tears, are pretty uncommon. That's a good pearl to remember. If you see an effusion in the shoulder and they have a cuff tear, look at the cartilage. 9 times out of 10, they're going to have a cartilage defect. Very rarely, not rarely, but uncommonly, cuff tears cause effusions. But here's an effusion. This is the synovium. Do you see the edema around the synovium? That's classic for septic arthritis, perisynovial edema. Anytime you have an effusion post-arthroscopy, it's septic arthritis until proven otherwise. You give contrast and there's diffuse enhancement of the joint space. Could you see that? Because the joint space is hyperemic. So septic arthritis. Another example, following ACL reconstruction, T1 weighted fat suppressed image, all this enhancement, enhancement of the bare areas, enhancement around the tracts, septic arthritis following surgery. Anytime you see a synovitis following surgery, septic arthritis until proven otherwise. You have to aspirate the joint. Shoulder arthroscopy. 2 gadolinium-enhanced images with fat suppression, joint diffusion, rim enhancement. This perisynovial edema is unusual in most arthropathies that aren't infectious. It's a pretty good sign that it's an infectious arthritis. So this was another septic arthritis with osteomyelitis. So we did a few pearls, we did image optimization, and we're doing global complications. We talked about seromas, hematomas, and granulation tissue. They all occur usually at the operative site and can look similar, although not identical. We talked about RSD, which shows you changes in the skin and occasionally in joints, but not causes marrow edema. We talked about infection, and I showed you examples mostly in joints, although you can get infection anywhere, I just didn't show it. And we're going to finish with adhesive capsulitis and our global complications. Although this is a post-op talk, most cases of adhesive capsulitis are not related to surgery. They can be from rotator cuff tears, they can be from trauma, they can just be from bad luck. That being said, it's not an unusual post-operative complication. Just post-op is not the major cause of it. We see them in the shoulder and the elbow, and interestingly enough, it's not frequent in the knee. You know, they do so many scopes to the knee, but adhesive capsulitis in the knee post-operatively is a relatively rare complication. Theoretically, intuitively, you would see decreased joint fluid. And you may see that, but that's not always true. You can have adhesive capsulitis with normal joint fluid. Absolutely, and that's not rare by any means. It's typically diffuse. In the knee, there is a focal form, particularly following ACL reconstructions, and you probably have all heard of this. Well, who has heard of this Cyclops lesion, out of curiosity? Yeah, I thought most of you have heard of it. That's adhesive capsulitis, and it's just focal adhesive capsulitis. That's really the only difference. It enhances like any kind of synovitis enhances. They call it a capsulitis, but it really is a synovitis. And what you look for is thickening with fibrosis of the capsule. We use 4 millimeters as our cutoff in the shoulder, but you can use 4 millimeters anywhere. So here is a coronal oblique T1, a coronal oblique T2. We see fluid underneath the posterior rotator cuff, right? You see no fluid in the axillary recess. That is never normal. You see a thin slit. Anyone, they have fluid in their joint. They just don't have any fluid in the axillary recess. And the way you measure this is you measure from that little drop of fluid to the cortex of the humerus. Because there is nothing between that fluid and the humerus other than synovium and capsule. And if that measures 4 millimeters, which I tell you it does here, that's adhesive capsulitis. And this is in my heavy animation stage. So to reiterate the concept of initial misdiagnosis and to talk about certain specifics of that. In the shoulder, it could be from the cervical spine, it could be thoracic outlet syndrome, it could be articular disease, glenohumeral articular disease, it could be a acromioclavicular joint articular disease, or it could be a rotator cuff that was irreparable from the beginning. And the way you diagnose an irreparable cuff is when there is diffuse fatty infiltration of the muscles. So if you have a patient who comes in, query recurrent rotator cuff tear, and there is one, look for muscle atrophy. Because if there was muscle atrophy, it was probably irreparable from the get-go. Now, are there any orthopedic surgeons here? Good. Because the orthopedic surgeons know this. It is in their literature. But they invariably try and repair these cuffs. And they have a legitimate reason. They're trying to do right by the patient. You know, even if there's a 20% chance of them getting better, they want to do that 20% chance. But it ain't going to happen. They're going to get better because you decompress them, not because you repair their cuff. So if you come in with a recurrent rotator cuff tear, look for muscle atrophy. It probably was there pre-existing. That means their rotator cuff was never repairable. In the knee, the most common mimicker for a recurrent meniscal tear is trochlea chondromalacia. This is very well known clinically to good orthopedic surgeons. Someone comes in, query recurrent meniscal tear, don't look at the menisci, look at the trochlea first. Then look at the articular cartilage away from the trochlea, then look at your menisci. A not insignificant percentage of these patients have lumbar spine problems. It's funny, one of the women working at the front desk is has purportedly meniscal tears on her knee, and she told me her symptoms, and she's got pain while driving, while moving the foot to the brake pedal, which is classic for lumbar spine disease and very atypical for meniscal tears. So I bet you that she has lumbar spine disease mimicking meniscal tear. She very well may have a meniscal tear, but it's not the symptom generator. So always remember that there may be concomitant disease and one may not be the symptom generator. So here's an example, patient recurrent rotator cuff tear, and we can see the small supraspinatus not filling its fossa, and this is atrophied muscle. If you see a patient who has a meniscal fragment, we're going to get to this in a minute, go out of your way to call it a recurrent meniscal tear. You see anything, even in your imagination, that you think is a meniscal tear, it is a meniscal tear. If you don't see anything, then they almost always have cartilage loss. Can you see the cartilage defects here? The cartilage defect there. And always look at the trochlea. This patient doesn't happen to have trochlea, but look at it. Okay, so we talked about some pearls. We talked about how to optimize image, mostly ramping the bandwidth, decreasing the voxel size, decreasing the TE, and using inversion recovery images. We talked about global complications, seroma, hematoma, granulation tissue, RSD, infection, and adhesive capsulitis. And we reiterated the concept that remember the initial misdiagnosis and that they may come in with recurrent symptoms, not because they have recurrent symptoms from their problem, but they had two conditions, one of which was a symptom generator. That is really a key concept. Now we're going to talk about some specific procedures. In the beginning, I said you don't have to know that many procedures. And we've already talked about this one, which is a tendon repair. And we've showed you examples. They can become thickened. They may have some internal signal. That depends on the tendon. In the Achilles, yes. In the anterior tibialis tendon, yes. In the posterior tibialis tendon and the rotator cuff, no. Okay, this is only true for T2, not for contrast enhanced. Contrast enhanced, all bets are off. Once they have a debridement, you basically won't see anything except scarring of the fat unless you give gadolinium. It's not important, but if they said it was a debridement and you see nothing, don't be surprised by that. That's very typical. It's very hard to see debridements. When you do re-tears, use your virgin signs, okay, but concentrate on morphology. You can use some signal in certain tendons, but concentrate on morphology. If the tendon is going to get infected, it's always going to be superficial tendons. So rotator cuff repairs never get infected. Achilles tendon repairs very commonly get infected. So the more superficial the tendon is, like someone asked a very good question about that quadriceps, would I be able to tell if it was infected or not? On that MR, I wouldn't. I recommended a Nutrispect. I would recommend a Nutrispect. And it's a tendon that has a high likelihood of being infected because the more superficial it is, the more skin inoculation and local trauma happens and they can get infected. So infections are usually superficial tendons. So here's an example of debridement. If we look here in the region of the PTT, do you see anything on this T2 weighted image other than the artifact and the navicular? Nothing, but if you give GAD, tremendous enhancement there, right? Does it matter? No, it doesn't matter. Just beware that if history says debridement and you don't see the debridement, no big deal. You won't see debridement often unless you give contrast. The anterior tibialis tendon, tendon to tendon anastomosis, does this look normal? Yes, right, it's just enlarged, no signal on this T2 weighted image. Here's the tendon to tendon anastomosis here on a contrast enhanced image. And signal doesn't matter in this tendon. Achilles and anterior tibialis tendon, we ignore signal. So this is a normal tendon to tendon anastomosis. Biceps, rotator cuff tendon. This is a tendon to bone anastomosis. This is actually more common than tendon to tendon anastomosis. Fortunately, is very easy to read. So how does this cuff look to you guys? Yeah, good. It's particularly the normal on my slide should be a giveaway. So this is a tendon to bone repair, But you use your virgin signs as if it wasn't operated on, and you'll be reasonably accurate. Here is a direct MR orthogram, okay, and we don't exercise them, so what do we know now? I can use my gadolinium now. That's why I don't want to exercise them. And I know that this is a re-tear right here. And if it wasn't a post-op shoulder, I would say the same thing, because it is the same thing. Okay, this is another suture granuloma of the Achilles tendon. Big, thick tendon on T1 and T2 weighted image. We see signal inside the tendon, but that signal is hypo-intense to fluid. Can you see that? Hypo-intense to fluid? So it enhances. And it is suture granuloma. But we know it's not a re-tear because it's not iso-intense to fluid like you would have in a, any virgin Achilles tendon. So we did pearls. We did optimizing images. We did global complications. We did remember the initial misdiagnosis. Then we went on to a specific category that's seen all over the body, tendon to tendon or tendon to bone anastomosis, and what you look for. Now we're going to do specific joints, and we're going to end in the last 15 minutes with specific joints. So we're going to begin with the menisci. And there are 4 rules of meniscectomy. And it's interesting, we did a study where we gave these 4 rules to different residents, first years, second years, third years, fourth years, and fellows. And we said to them, does this postoperative meniscus violate the 4 rules of meniscectomy? And even first-year residents were able to diagnose post-op menisci with the same accuracy as musculoskeletal fellows, knowing the 4 rules of meniscectomy. So it behooves you to know these 4 rules. They're not hard. Rule number 1 is preserve as much meniscus as possible. Rule number 2, surgery, never violate the periphery. Rule number 3, avoid sharp margins. And rule number 4, keep a meniscoid shape. So these are the rules. How do we image them that we violate them? Well, preserve as much meniscus as possible. Small menisci are usually retorn. That's the violation of that rule. So the smaller the meniscus, the higher the rate of retears. And remember, we're dealing with a skewed population because they're only coming for images because they have symptoms. We're not imaging all patients who have small menisci. We're imaging those with small menisci and symptoms. And that group of patients, extraordinary risk of re-tear, like over 90% without even looking at the menisci. Rule number 2, never violate the periphery. Lines that extend to the edge of the meniscus are re-tears because they'll never do something to the periphery of the meniscus. Rule number 4, avoid sharp margins. Any fluid inside a meniscus is a re-tear. Rule number 4, keep a meniscoid shape. And the caveat for this is they may be rounded. But if you see something that looks either not rounded or distinctly not meniscoid, that's a re-tear. I put this on the bottom because you almost never apply that one. Basically, you're going to apply rule number 1 and rule number 4 in 90% of your circumstances. Small menisci are usually torn. If there's fluid inside a meniscus, it's usually torn. If I don't use those rules, treat it as a virgin meniscus. So this is the case I showed you before without a re-tear, even though it's a small meniscus. Okay, so here is a patient. How big was this meniscectomy? Small, medium, or large? Yeah, small to medium. Certainly not large because we see a lot of medial meniscus here. Here's your T2 weighted image, and here's your PD image. Is this a meniscoid shape? Well, this is not a triangle, nor is it rounded. Can you see how it's neither a triangle nor rounded? It kind of looks like a diamond cutting into the meniscus. Can you see that? Yes, no, maybe? So that is a re-tear. That is not a meniscoid shape. Now, it doesn't have high signal on a T2 weighted image, but there is a meniscal cyst. Can you guys all see the meniscal cyst? And when patients have meniscal cysts, they almost always have re-tears too. It's not on my slide, but that's a pretty good rule. So if I look at this, this is not a meniscoid shape. So we can use our virgin signs with a surprising degree of accuracy. As I just mentioned in the previous slide, if there's meniscal cyst, it's usually a re-tear. If there's an extensive meniscectomy, not only is it retorn, but there's probably going to be articular cartilage loss. So let's look at this meniscus here. This is a T2 weighted image with fat suppression, a T2 weighted image without fat suppression. Is this a regular meniscoid shape? Plus or minus, but certainly this bottom part does not look regular. Can you see that? And that's not a nice rounded triangle. It's kind of a peculiarly shaped triangle. Can you see that? Can you see that? But even that being said, this is fluid in the meniscus, right? This is not a PD. This is not a T1. This is an inversion recovery image. So it has to be re-tear. Anytime you see fluid in the meniscus, it has to be a re-tear. Questions about menisci?
Do you ever give intra-articular contrast?
Used to a generation ago. You know, for me, I used to, but not anymore. Again, when I came to New York, you know, there's the traffic is a culture shock. The fact that someone would open a golf umbrella on a street with 40 people around them was a culture shock. And the fact that people almost never give gadolinium for anything was a culture shock. And I got used to reading through it, and I found that there's a legitimate reason for it. And I don't think, you know, everyone gets used to what they're used to doing. And you get better at doing what you're used to doing. And I think if you're used to giving gadolinium, you'll be really good at using gadolinium. In the abstraction, if I had a choice of giving it or not giving it, at this point I probably wouldn't give it. I don't think I need it. Another question?
What about the timing after the surgery? Because I mean, there are changes as time progresses.
Yeah, let's talk about that globally because it's a really good question. So when I look at post-op patients, I look at them, do they come in 6 months after surgery? Do they come in 6 to 12 months after surgery? Or they come in more than 12 months after surgery? Okay? If they come in less than 6 months after surgery, I got 3 choices. Choice number 1, I know it wasn't really addressing your question. Hopefully I'll remember and I will in a minute. But first in 6 months, either the surgery was done for the wrong reason, they have infection, or uncommonly they have RSD. Those are my 3 choices. They come in 6 months after surgery. Come in 6 to 12 months after surgery. They can still have infection. They can still have RSD. They may have developed cartilage loss, or they may have developed synovitis. When someone comes in more than 12 months after surgery, then that surgery could have failed. Now, the notable exception to that is 2. You can get recurrent disc herniations less than 12 months after surgery. They're uncommon, but by no means rare. And you can develop recurrent osteomyelitis less than 12 months after surgery. But you don't develop recurrent meniscal tears. You don't develop recurrent rotator cuff tears. You don't develop recurrent Achilles tears. You don't develop recurrent anterior talofibular ligament tears. None of them get recurrent after 12 months. So are the signs I'm using, do they vary temporally? Hell yeah. Does it matter? No. Because if you're thinking of a recurrent rotator cuff tear, that signal will have normalized by that time you should consider a recurrent rotator cuff tear. So all this literature about how the ACL graft looks like at 2 weeks and at 4 weeks and at 6 weeks is fine and dandy, but no one re-tears at 6 weeks or 12 weeks or even 4 months. Does that answer the question?
So less than a year then you're not concerned about the original, then a re-tear then, really?
It just doesn't happen. You know, will you see a case every 5 years? You'll see a case every 5 years, but no more than that. Except for recurrent osteomyelitis and recurrent disc herniations. Those do happen less than 12 months. Other questions? Okay, so continuing in the ACL reconstruction. So the signal returns to normal in answer to that gentleman's question pretty quickly, about as quickly as you could reasonably expect for a patient to have an Achilles re-tear. I've never, and this is a strong statement, had a diagnostic difficulty that I wasn't sure if it was a postoperative change or a recurrent tear. They just don't come in that early. If they do, they're worried about a septic joint, not an ACL re-tear. They get 2 types of re-tears, they should say. Traumatic, like a typical traumatic ACL tear at close to the origin, about 5 millimeters. An attritional tear or graft roof impingement at the mid to distal ACL reconstruction. If they have a bone patella bone reconstruction, doesn't matter if you know what that is or it doesn't. Just look for a low-lying patella called patella baja. not uncommon complication, and they get chondromalacia from that. This is a knowledgeable audience. Most of you have heard of the cyclops lesion, focal arthrofibrosis anteriorly. They get osteoarthritis when the reconstruction fails. It looks like osteoarthritis in any other knee, except they must have patellofemoral disease. If they don't have patellofemoral disease, the osteoarthritis is from the meniscectomy that they probably did with that, not from the ACL reconstruction. Okay, so here is what an ACL graft should look like on T1, on post-gadolinium, and I like this because the orthopedic surgeon gave me the arthroscopy where you see the normal ACL graft. This is early graft roof impingement, where we see some subtle signal inside the mid portion of the graft. Traumatic tears occur at the proximal portion of the graft. Cartilage procedures and osteochondral procedures, and we'll finish with osteomyelitis and right on time. You have to understand the natural history of these procedures, and they're evolving so quickly. You know, I have trouble keeping up with them. And again, I'm lucky. This is the only thing I do. And it's much easier for me than for you guys who usually have to know more than one thing. My database is pretty limited. So no one expects you to know all the different procedures. If they do, they're being pretty unreasonable. If you look at these, just try and be intuitive. Say, is this what I would want my articular cartilage to look like following surgery? Simple question. So if there is the Oates procedure and the plugs are proud from the surface, I wouldn't want my articular cartilage to look like that. If it was a bone graft for an osteochondral defect and I see fluid at the bone graft bone interface, I wouldn't want my bone graft to look like that. If it was a Genzyme procedure and I see no cartilage, where they purportedly transplanted my own cartilage at a cost of $5,000 cash, not covered, I wouldn't want my cartilage to look like that. So you don't have to know the procedures, just know a little bit about what they look like. So here is one. So this was a debridement. They scraped the cartilage under the principle that they'll cause hemorrhage. Some totipotential cells would go in there, and you would reform cartilage. And would you want a big cartilage defect following that? No. The cartilage should have been regrown. So this is an unsuccessful debridement. Why is there marrow edema here? Because they pricked the bone. To debride this, you have to get bleeding bone and you have to prick like a toothpick the bone underneath it. And the more mucking around you do in the bone, the more marrow edema. And this was several years after the procedure, if I remember correctly. How about this one? Well, we see marrow edema around it, but no fluid. And if I looked at the articular cartilage looks good, right? And I would say I would like my ankle to look like this. I read this as an unstable OCD graft. They trusted me, which was a mistake. And they went in arthroscopically, and the cartilage was completely normal overlying it. So you want to look at the articular cartilage. The underlying bone may be helpful, but based upon how much mucking around they did in that bone, you may see more marrow edema. Here's a patient who had an OCD graft with a screw. I see contrast enhancement at that interface. That's not marrow edema from them putting the screw in. That's an interface that never healed. And that's a non-healed osteochondral defect. Again, a bone graft here, and we see violation of where the cartilage should be. So abnormal healing of the cartilage. I want to skip because I want to get in the last 3 minutes to infection. They debride usually soft tissues more than bone. Currently, they try and do as limited an osseous resection as possible. The amputations are often non-traditional. They don't do just a Chopart or a Liz Frank amputation. They just take out the infected tissue, and that's somewhere between a really extensive debridement and a true amputation. But you don't have to know this. The principle of osteomyelitis surgery is you take out all the infected bone. If the soft tissue is not adequately vascularized, you take it out, and then you give IV antibiotics for everything else. That's the surgical principle. Everything else is just overly detailed. So this patient had a debridement here of the calcaneus. Can you see where there's a concavity of the calcaneus? We don't care about this enhancement. We see abnormal T1 weighted edema signal, right? Does this look like they finally debrided that, or you think they cut that? Because that would be the question to try and decide how much marrow edema there is. It looks like they cut this, and therefore this is recurrent osteomyelitis. Another patient, status post mid-metatarsal amputation. Is this a direct cut or a fine debridement? Direct cut, right? They take the guillotine and they just chop off the toes. So should you see marrow edema? No. And these break down pretty quickly, and you can see the marrow edema on the T1 weighted image. So all these are infected. So in the last 45 minutes, I talked about postoperative imaging. The first thing we talked about is some pearls, and that's all in your handout. The second thing about how to optimize images. The third thing is global complications. Seroma, hematoma, granulation tissue, RSD, infection, and adhesive capsulitis happens at all orthopedic, or has the potential to happen at all orthopedic procedures. We emphasize the concept. Consider the initial misdiagnosis, particularly when they come in 6 to 12 months after surgery. Then we did a few selected procedures, and we talked about how to image their complications.